Thanks. It's a bit random, but when a cyst is removed, then biopsies are obviously sent off to give each patient a mitotic count of the spread. So approximately how many cells are there in that 5 millimetre square bit that's used to calculate the mitotic count?
That's a very good question. I don't think I can give an accurate answer.
Well, ballpark, like massively ballpark.
How big was the size, sorry?
Well, I think they 5
5
millimetre square is the standard thing that they...
There's millions, yeah.
Is so that right? That's to give you your mitotic count?
The slide that Jack showed,
yeah.
Spatial thing we do,
yeah.
6 millimetres by 6 millimetres.
Okay.
So that gives you an idea of how large something is, but they won't use the whole thing to calculate.
No.
They're based on HPFs, aren't they? High-powered fields.
Yeah, HPF.
Yeah.
I suppose the thing that's the reason for me, this is just a very, it's a very personal question because my mitotic count of high-risk cells was 6, which made the difference as to what. So one cell difference made the difference as to whether I had 3 years of imatinib or not, and it was a really hard line. And I suppose what I can't get my head around, it's finished now and I'm done, but it's that kind of thing about, well, how many cells are we talking about? Because if we're talking out of 10, you think, okay, that's fine. Yeah. But it's much more than that, isn't it?
We routinely get 8 millimetre biopsies, and from those we're able to get millions of cells. So it's hard to estimate a number and...
So when a mitotic count is calculated, and really you're better off with the pathologist talking about this, but essentially they don't just look at one area, count it once, and then make a decision. So they'll take an area, they'll do it multiple times, and they'll essentially, so you won't just have one value before they make a decision. They'll look across, the way we do it in the lab as well is the same way. We'll have a field of view, we'll select an area, we'll count that area, and then we'll repeat that many times to then basically say, okay, it gives you then what is the kind of range. So Jack used this word heterogeneity, we use it all the time, but essentially say what's the variation across this whole area that I've got, and then look for the kind of average. And then they'll always make the most conservative estimate rather than the kind of least conservative, so that whatever decision is being made in the most sort of appropriate way, the most conservative way, rather than the most, oh well, the lowest value is this, we'll run with that. They'll definitely go, okay, if this is the highest, we'll err on that side, and so that's how they do it. All right, no problem.
Hi, I've got 2 questions. In your opinion, how realistic is the scenario for immunotherapy for GIST in the future?
So in GISTs, immunotherapy doesn't work particularly well, but that's not to say that it won't work in the future. And interestingly, we are looking in our lab at ways that we can encourage it to work. I mentioned about that a drug called an EZH2 inhibitor, and the idea of that is that it affects the cancer cells directly, that it affects their proliferation, and but it also encourages the cancer to present more to the immune system. And so when they present more to the immune system, then there can be more of an immune response to that. So whether we can use immunotherapy as well as an EZH2 inhibitor, it could provide some benefits. Yeah.
And the other question is, I know your talk wasn't on AI, but perhaps you may be able to answer this. Do you think it's realistic that AI could in future be actually involved in drug design for this particular type of cancer?
Yes, that's a very good question, and Zoe looks very keen to answer, but that is something that we do quite a lot in our team across different sarcomas.
My question is, are you talking about new drug discovery? Or, like, if you're talking about that?
Yes.
Yeah. It's always quite hard in sarcomas because of how rare, relatively speaking, they are. So whilst you can do in silico drug design against a new target, and you can do that relatively cheaply now, the problem is always in the drug development. And so we spend, particularly in the sarcoma field, we're really keen on this idea of repurposing what's already out there, because, and Robin would tell you the same, the problem you often end up with in the kind of rare cancer field is how do we actually get a drug A made, B, a drug company to buy in and give us the drug to go into a trial. And so we sort of say, okay, if we want to do something quickly for patients, if we focus on something where the drug already exists, so that whole pipeline that's extremely expensive already exists, then actually we might get some traction here. So I think Robin's AI work is where we'll see more evolution in that space, because we can sort of use the full might of AI, machine learning, deep learning in the kind of predictive space, predicting recurrence, relapse, the length, potentially that kind of thing, more so than perhaps the kind of new drug discovery. That would be my guess.
And famously, imatinib was one of the first repurposed drugs. Accidentally found it, shrunk a tumour, which we know was GIST. Okay, so we'll now move on to Matt, if we may.